So, good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from Clarinet, assigned as a station assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet is a digital partner of this event organized by Indian Medical Association Medical Students Network, Haryana. The topic of today's session is Know Your Heart. So let's begin today's session, for which I would like to hand over this session to Dr. Kushal. Over to you, sir. Kindly proceed with your talk.
I warmly welcome all the participants and very obviously our honorable guest, Dr. Kushal Markanday, sir. Talking about the webinar for today, Know Your Heart is an objective taken up by the Academic Subcommittee of Haryana State Council and which will include all the information about heart failure and a short quiz which will be led by Dr. Kushal sir himself. A brief introduction about Dr. Kushal sir. He is an assistant professor at MMI MSR Mullana. His specialty lies in medicine. He has attained the MBBS degree from Himalayan Institute of Medical Sciences, Dehradun, and has completed MD in General Medicine from MVJ Medical College and Research Hospital, Bangalore. His other notable achievements include submitting 6 publications. He is also a founder of UVARDI Himalayan Institute Hospital Trust at Dehradun. He is a skillful teacher with an experience of 5 years. Known for his presentation and oration skills, he is admired by his students for making the concepts easier and indelible. A brief introduction about our committee, without whom this event wouldn't have been possible. The president, Prableen, and myself, Juveri Ansari. The secretary, Balihar ma'am. IT head includes Sayam and Vanshika ma'am. And PR and communication heads handled by Zubia and Kshitij. With that, I would like to give the participants a brief overview about the visions of IMA MSN. IMA MSN is a students' wing aiming to connect medical students from all the medical colleges in India with the same goals and purposes as IMA, while also providing a means of curricular and extracurricular activities to the students. The objectives of Indian Medical Association are the following: to sensitize the students in Medical College of Modern Medicine about IMA and its activities with an aim to enroll them as a member of IMA in the future, to help and guide them regarding future prospect in medical career, education, ethics, research, and employment avenues, to help and guide them to intervene if any problem arises during their educational career, to identify talents among MBBS students and to help them for further improvement, to involve them in various social and cultural activities and national health programs, and to publish matters towards accomplishing the objectives. Now, with all these advantages of becoming a member of IMA, I extend a warm, welcoming hand to all the participants to kindly consider joining this community, the registration link of which will be forwarded in the group shortly. With the brief introduction done, I would kindly invite Dr. Kushal sir to take up the mic and begin this beautiful journey of knowing your heart. Thank you so much. Kushal sir, please lead over.
Hello, hello everyone. Hope you are all hale and hearty. And my apologies for spoiling your weekend. I'll be just taking 1 hour on your heart.
Good afternoon,
It's
sir.
a very good afternoon, students. Now, the thing is, everyone has talked and heard about heart from the day we are born. Actually, uh, हम अगर गायनेकोलॉजिस्ट पे जाते हैं सबसे पहले एफएचआर चेक करता है फीटल हार्ट रेट सोचते हैं कि यस द हार्ट इज फाइन ठीक है फिर बच्चा पैदा होता है फीटल हार्ट रेट देन अगेन द मोमेंट यू बिगिन योर लाइफ हार्ट दिस इज द वन थिंग which beats till the end of your life from the beginning till the end and this is why you are alive because of your heartbeats now heart the basic function we all know that it pumps the blood and the other function, which we actually fail to recognize, is that it receives the blood from our entire body back. Now, the thing is, why this receiving function is also important is because if the heart fails to receive the blood back into it, the heart will not be able to circulate it further. So, again, our receiving function is also important. Point number one. Point number two, pumping of the blood is okay, receiving of the blood is okay. Still, there are certain things in a heart which are actually important. Like, number one, the beating of the heart. The heart beats. Okay. So, if there is an abnormality in that, that also leads to a failure. Okay. So, heart failure is a complex term in which both structural and functional abnormalities of the heart are considered at once. There are many guidelines, many associations all over the world which define heart failure differently. And the number of guidelines you go to read, there will be n number of definitions for it. So, to simplify it as only structural and functional abnormality of heart. That is your heart failure. To understand it better, now we'll talk about in detail about a simple thing called cardiac cycle. Now, cardiac cycle begins when your heart receives blood from your peripheral circulation, that is from your IVC, SVC, inferior vena cava and superior vena cava, and back into your right atrium. From the right atrium, via the tricuspid valves, the blood goes to right ventricle, and from the right ventricles, it goes back to lungs to get oxygenated. And in the lungs, we have oxygenation of the blood, and from the right ventricle to the lungs, the blood is going via, can anyone tell me? Pulmonary arteries. So the pulmonary arteries take the blood from your right ventricle to the lungs to get oxygen. From the lungs via the pulmonary vein. See, artery takes the blood from the heart away, and vein brings the blood back to the heart. So pulmonary veins bring the blood back to your left atrium. And from the left atrium, the blood goes to left ventricle via the mitral valves. Okay. Students, can anyone just turn on the fan? Yeah. It's actually very heated. Okay. So from the left atrium, the blood is going to the left ventricle via the mitral valve. Now, from the left ventricle, it goes to the aorta. We all know this. This has been repeated n number of times. Now, to understand heart failure, this is actually the only thing which you need to know. There is nothing more in heart failure more than cardiac cycle. If you know your cardiac cycle, you will be the master of heart failure. I tell to all of my students. Okay. Now, keep this in your thoughts. We'll come back to it later. We'll jump back to heart failure just a little. Now, There are n number of causes of heart failure. So it can be a systolic failure where the heart failure is not pumping the blood out of it, where the cardiac output is decreased, or it can be a diastolic failure where the heart is not able to contain the blood. Okay. Now, when the heart failure is actually setting in, diastolic failure actually precedes the systolic failure. So it is the filling which gets deranged first, and then comes the systolic failure. I'll be discussing it little in the detail. The thing is, whenever there is something acute happening, say for example, there is ischemic heart disease, when there is a myocardial infarction, whenever there is a myocardial infarction, there is loss of regional wall motion abnormality. So your whatever wall is getting involved, whatever the wall is getting infarcted, that is where the pumping is not happening. So in such cases, there will be direct systolic failure. But if at all there is a systemic metabolic cause, there will be diastolic, which will be preceding. Huh? I don't want it, don't worry. Okay, I'm happy like this. Now, the thing is, actually, my support team is like, getting very tensed. Not a problem. No need to worry. Okay. Now, the thing is, in systemic conditions like in diabetes, you'll be surprised to know that there need not be anything more than diabetes in a diabetic patient to actually precipitate a heart failure. Hypertension, we all know, can lead to lead to heart failure. But did you know that even diabetes causes heart failure? Just the patient being diabetic is enough for predisposition of a patient to heart failure. So much so that the filling pressures inside the heart will be elevated beyond normal. So much that whenever from the lungs, whenever the blood has to enter the heart, say for example, left atrium, and then from left atrium to the left ventricle, the pressures will be high enough for the blood to be hindered to come inside. In simple languages, just imagine that there is a glass of water. Okay. And from that glass of water, you have to transfer this water into another glass. Now, if that another glass is empty, you'll be able to empty it out completely. But just in case there is only half of the glass empty, you'll be able to empty out only half of it. And you'll have still half of the glass full in the glass, which was supposed to be completely empty. That is what is happening in heart failure. Coming back to this concept again, many a times we hear it that in heart there is breathlessness, then in heart there is pedal edema, like swelling of the feet. Then in heart there can be chest pain also. There can be palpitations also. Any symptom related to heart, we equate it with heart failure. Let's have a clarity of vision about it. It's not only this much. The clarity of the vision comes with the understanding of cardiac cycle, which I began in the beginning. So say, for example, the same concept from jar A to jar B, you have to transfer, say, for example, 10 liters of water. Jar B is empty, jar A is full. Okay? Now, if you have to transfer it out like that, what will happen? That if the jar B is completely empty, you'll be able to completely empty the jar A. Say, for example, there is refusal from jar B that I refuse to take any more water. Where will the water get accumulated? In jar A. definitely which was supposed to be empty, there is still water. Same concept we apply in your right heart and in left heart. Say, for example, blood had to come from inferior vena cava to and superior vena cava back to the heart. And now the right side of your heart refuses to take blood. Okay. So there will be refusal to take blood from your in right side of the heart. And then where will the blood get accumulated? Either in the SVC or in the IVC. So this brings us to a very important section of our today's talk, that is clinical features of heart failure. The clinical features of heart failure, if it is right side, like we are just now talking, it will include number one, if there is blood or fluid getting accumulated in the SVC, that is superior vena cava, that is superior venous circulation. Okay, there will be elevated jugular venous pressure. Okay, so the JVP will be raised. And if at all the JVP is raised, there will be increased pressures in the venous circulation anywhere else also. Okay, now if there are increased pressures anywhere else, where all you can see it? Actually, you can see these increased pressures in the form of pulsations in your eye. So orbital pulsations can be seen. If you look at the fundus, there will be increased pulsations in the eye. That is another point. Okay. Then coming over to the inferior vena cava circulation. If in right side of the heart failure, there is accumulation of the blood in the inferior vena cava circulation, what we have is number one, pedal edema, swelling of the feet. Okay. My students sitting over here are actually being uh, given another set of revision from me. Ascites. Then you can have distension of fluid in the portal circulation. Okay. So you can have tender hepatomegaly. Okay. In certain cases, this tender hepatomegaly is so much that you can actually see a pulsatile liver in certain cases. So that also can happen, especially in patients who are having tricuspid regurgitation. So you'll have a pulsatile liver in that. So it's actually quite important. Now, if there is ascites, you'll not be able to appreciate organomegaly in certain cases. But if there is ascites and pedal edema, that in itself is sufficient enough to call it as a heart failure, provided it is a cardiac setting, which we are talking about. Now, I will discuss the chronology of edema later on. Just give me a second. Now, we'll come back to the left side of it. People will be very much excited at times that yes, there is a heart failure, there will definitely breathlessness. We just now discussed that in right heart failure, there was no feature of breathlessness anywhere. We just now discussed. So if there is right heart failure, breathlessness didn't come into picture. If there is a pulmonary arterial hypertension or something like that, which is precipitating heart, then there will be breathlessness, but not because of the heart getting involved, because of the lungs being involved. So if you are thinking of cardiac causes of breathlessness, right heart doesn't come into picture at all. It is the left heart. How? Because in left heart, you see the blood. Now, like in right heart, the blood was getting accumulated in IVC and SVC. Okay. But in left heart, where will the blood get accumulated? The blood will get accumulated in the lungs. Okay. Because these were the lungs which were giving blood to the left heart. Okay. So when lungs are giving blood to the left heart, and if left heart refuses to take the blood anymore, okay, now the blood will get accumulated in the pulmonary circulation. And in pulmonary circulation, if there is fluid overload, if there is fluid overload, see, always remember one thing of your physiology class, that cells never leave the capillaries. It is always the fluid which leaves capillaries. Okay. Now, if the fluid is leaving the capillaries, okay, what will happen? There will be pulmonary edema. And this is this pulmonary edema which leads to breathlessness. Only breathlessness is not actually the hallmark of heart failure. Again, left-sided heart failure. Sir, first you tell there is breathlessness in heart failure. Now you are telling only breathlessness is not the hallmark. There are much more things to this breathlessness. This breathlessness is actually special. How and why? Why we are calling it as special entity is because number one, this breathlessness is exertion dependent. So the degree of exertion you are having in precipitation of your breathlessness actually grades it. Now, grading of the breathlessness is given by NYHA, New York Heart Association, okay, of heart failure. That for all cardiac breathlessness, we use that only, NYHA grading. And many of you might have heard of it also. Okay, so I will ask you one simple question. Okay, I can have in the chat box to see how many people are actually active in this, actively listening, because to listen, you'll have to utilize ATPs, and but to just hear, you need not. So, how many of you are actually hearing this or listening this? In NYHA grade 1, where there on ordinary physical activity, there is a heart disease existing in the patient or not? How many of things? If you think that it is there, comment as Y. If you think the heart disease is non-existent at NYHA grade 1, you comment as N. No. Let's see how many of you are still with me in the train. Are we getting any responses? Hmm?
Sir, please repeat your question.
In a case of New York Heart Association grade 1, which is there is no limitation with ordinary physical activity, do you think the patient is suffering from a heart disease? Yes or no? So the majority wins. Majority is correct. Yes, there is a heart disease, but it is not getting precipitated at ordinary physical activity, and there is no limitation at all. How is this happening? There is a heart disease, and still there is no limitation. So that means, is there something called permissible heart disease? That this much amount of heart failure is permissible. That if you have this much amount of heart failure, you will not have anything. Is it like that? Because majority is telling that there is heart disease, but still there is no limitation of the ordinary physical activity. Well, there should be a, see, if there is heart disease, if I am in heart failure, okay, I cannot do any ordinary physical activity, and still you are telling that I'm not having any limitation of ordinary physical activity. Still you are telling that I'm having heart failure. That is where your breathlessness on exertion comes. How exertion is affecting your heart is number one. There is increase in the functioning of your heart on exertion. So your myocardial oxygen demand increases. At ordinary physical activity, I was getting adequate blood supply to my heart, that I was not having any issue. Now my cardiac workload has increased. Okay, so I will require more nutrition for myself. That is where I feel difficult. This is breathlessness or angina or palpitations or fatigue or any cardiac symptom on exertion, which is actually precipitating. Okay, so number one, there is increase in the cardiac workload, which leads to increase in the myocardial oxygen demand. That is when heart starts to fail. Okay, now next trivia. So, okay, your heart has started to fail. Coming over to NYHA grade 2, which is slight limitation on ordinary physical activity. Okay, NYHA grade 3, which is what? Marked limitation on ordinary physical activity. Then NYHA grade 4 is breathlessness even at rest. Okay, so now we understood one thing, that systolic function need not be impaired primarily for a patient to have any precipitation of heart failure. So the pumping of the heart is normal. Still, there is dysfunction of the heart. That is because of diastolic dysfunction. We as clinicians and many philosophers or anatomists or physiologists, whoever has been associated with the concept of heart failure, has always told whenever the pumping of heart cessates, your heart fails. Whenever there is low ejection fraction, your heart fails. No, it is nothing like that. Your ejection fraction can be normal or even high at times, elevated above normal. Still, you will be in heart failure. Your cardiac output will be normal. Your cardiac output can be elevated also. Still, you will be in heart failure. Okay. So, that is our diastolic failure, that the heart is not receiving the blood adequately. Okay. So, whenever the pressures inside the left ventricle are high, that is elevated filling pressures. See, we need a negative pressure inside the left ventricle to receive blood from the left atrium inside, right? When there is a negative, apparently negative blood pressure inside your left ventricle, then only you will be able to receive the blood. Okay. What if this negative pressure is not adequate enough? Okay. Now, there will be difficulty in pushing of the blood from the left atrium to the left ventricle. Getting my point? Simple. Okay. And this is the basis of your diastolic heart failure. Okay. Or which we proudly call it as heart failure with preserved ejection fraction. Okay. I am seeing some eyes glittering with knowledge here. Okay. There is nothing. This is just simple concept. Okay. So heart failure with preserved ejection fraction. This is where your exertional dyspnea comes into picture. People tend to ignore exertional dyspnea in initial stages. How? If I am having exertional dyspnea, I will limit my activity on my own. Say, for example, if I had to climb 2 flights of stairs to reach my office, I will start taking automatically. I will start taking lift. Okay. Or if I'm having exertion or palpitations or any dyspnea on walking fast, I will automatically try to adjust my pace of walking and I'll walk slowly. Okay. So for a long time, your diastolic blood pressure, your heart failure with preserved ejection fraction is ignored by the patients. That is where the knowledge of heart failure comes into use. If you have the knowledge of heart failure, you will be able to detect heart failure when it is actually in the beginning stages. And if you intervene at that point, believe me or not, your patient's life will be improved beyond your imagination. Because once the cardiac remodeling has set in your heart, there is actually very narrow window which you can enlarge enough. Okay, which you can actually stretch. So now, say for example, I bring you to breathlessness on exertion. Over, done and dusted. Many of you now understand that what breathlessness on exertion is. Diastolic failure precipitates, then your myocardial oxygen demand is increasing. Okay, and your cardiac workload has increased. You are having breathlessness on exertion. Okay, got it. You can have any cardiac symptom on exertion because of this concept only. Now, is it only breathless on exertion or much more than that? Actually, there is much. Now, say for example, in night, you are sleeping. Okay, you are having heart failure. You are having initial stages of heart failure, not progressed. Okay, and it is just the initial stage of heart failure. At this time, you are everyone. Remember your physiology class. You know that there are two phases of your sleep. One is REM, another one is NREM. Your sleep begins with NREM stage, which is 90 minutes long. Sir, heart failure class, what are you doing with REM and REM? We are already feeling sleepy. Nothing like that. Okay. So in NREM, you are beginning. You are having parasympathetic activity. Okay. You'll sleep aram se. You'll sleep peacefully. For 90 minutes, you are not having anything. Okay. Now, REM clicks into picture. Suddenly, there is sympathetic overactivity. Now, one thing majorly which is happening, which is the difference for the heart. If you look from cardiac point of view, if you look from heart point of view, you will be noticing that on standing, there is the dependent area is in the feet. But when I am erect, the dependent area is in the feet. But when I am supine, that is where the dependent area is in the posterior aspect of your body. Okay. And this is where your venous return gets equated to. So the venous return of your heart increases in the supine position. We all know this. There is no Greek and Latin here. Okay. Venous return of the heart increases in supine position. Okay. It's okay. Now look from lungs point of view. So your heart has started to fail. Is now some, see, more blood in the heart means more work for the heart. Okay. Preload. So venous return is nothing but preload to the heart. So if there is more blood, if there is more blood, so the heart has to work more. Okay. Now, somehow, since heart has just started to fail, it will still able to be okay with it. Okay, if there is more venous return, I will still be able to manage. You will not have any symptoms. You sleep peacefully. Don't worry. Now, REM comes into picture. There is sympathetic overdrive. Now, heart will be like, sir, I am already failing. Okay, you are increasing heart rate. You are increasing sympathetic drive. Okay, how much this seemingly elderly person has to work more? Okay, now I will show you what I am. Now, heart will show the symptoms. Now the symptoms will come. How? See, when the heart has failed, there will be little amount of pulmonary edema. Okay, because left heart has failed. Okay, left heart has failed. Little in the starting phase only. So little pulmonary edema will be there, but you will not have any symptoms because somehow with pooling of the blood in the dependent areas or something, you are able to manage. You have lied down, venous return increase, more blood in the pulmonary circulation because right heart will not keep the blood with itself. Right heart will push the blood to the lungs. More blood in the pulmonary circulation. Now, say for example, okay, you are able to go with it. Now, heart rate has increased in REM sleep. So, more blood in the pulmonary circulation. Okay, that is where your pulmonary edema tells that now I will show you what I am capable of. So the person will get up from the sleep, will have breathlessness, okay, will run towards the window for air hunger, okay, because pulmonary edema was there, now increased because of sympathetic overactivity, okay, and see, edematous fluid was there in the alveoli. You are taking deep breaths. Now, when you push, any one of you has blown uh, air into a soapy water, bubbles form, na? So froth will be formed inside your alveoli, and the cough will have a pinkish hue because of leakage of blood from the small distended capillaries. Okay, so girls will be able to understand better. White color with little red will turn the color into pink. Yeah, see, these people understood. Okay, so this pink frothy sputum with night awakening, okay, with air hunger and breathlessness is a classical feature of paroxysmal nocturnal dyspnea. Okay, so there was number one, increased venous return. Number two, the sympathetic overdrive. See, sympathetic overdrive is nothing but exertion for the heart. The concept is same, but instead of this, I have held the ear like this. Simple. Now, okay, sir, paroxysmal nocturnal dyspnea. Till some extent, we have understood. Okay, I need, I do not need you to master heart failure today with me. I just need you guys to stay with me till the end, and I'll be successful. Okay. Now, say for example, paroxysmal nocturnal dyspnea remained there somehow with the while by elevating the head end of the patient, we sailed through the boat. What if there need not be any exertion and only increase in the venous return to the heart was enough to precipitate breathlessness because of pulmonary edema in a setting of left heart failure? So just lying down supine on bed is enough to precipitate breathlessness. So this is one grade above paroxysmal nocturnal dyspnea. And we call it as, any answers? Orthopnea. Okay. So now we are having orthopnea. So just lying down supine on the bed, increased venous return to the heart. Okay, to the right side of your heart. Okay, then increased pulmonary congestion. Okay, and increased pulmonary congestion leads to increase in the pulmonary edema, and that is enough to cause breathlessness. So breathlessness, which is aggravated on lying down flat on the bed, that is orthopnea. Now, okay, sir. Breathlessness on exertion we understood. Paroxysmal nocturnal dyspnea we understood. Then orthopnea also we have understood. Sir, what else? What else? See, We talk about pedal edema in right heart. We talk about raised JVP in right heart. We talk about orbital pulsations in right heart. We talked about ascites in right heart. We talked about tender hepatomegaly in right heart. We talked about breathlessness on exertion in left heart. We talked about breathlessness in after 2 hours of sleep in left heart. We talked about breathlessness on lying down flat in left heart. Is there anything else? Yes, you can have any other symptom, that is palpitations. You can have palpitations is nothing but abnormal awareness of your heartbeat. Believe me or not, you need not have tachycardia while having palpitations. Okay? We actually have a perception that whenever we have tachycardia, then only you are going to have palpitations. No, it is just abnormal awareness of one's own heartbeat. That is what palpitations is. Okay. So you can have it even in normal heart rate. Okay. Then you can have fatigue. You can have chest pain, chest discomfort. So there are many things. Okay. All these are cardiac specific only. Now, clinical features over. Sir, you talked about clinical features. Sir, you talked about definition of heart failure. What next? Now, we are going to talk about a very simple thing in heart failure. We are going to classify our heart failure based on the what? Yeah, you wrote it correctly. That is ejection fraction. So ejection fraction, when it is less than 40%, we call it as ejection heart failure with reduced ejection fraction. When your ejection fraction is between 41 to 49, we call it as heart failure with mildly reduced ejection fraction. When we call it as heart failure with preserved ejection fraction, the ejection fraction will be more than 50%. Okay, then there is a heart failure with increased ejection fraction that is seen in your high output states. High output states like hyperthyroidism, wet beriberi. Okay, so your ejection fraction will be very much elevated than normal in heart failure with increased ejection fraction. Okay, heart failure with preserved ejection fraction is nothing but diastolic heart failure, which we discussed in the initial. Now, say for example, your heart failure is with reduced ejection fraction, and you start the patient on treatment. Okay, we'll discuss about treatment in brief time because there are many second year pharmacology students sitting here who will actually be asked about heart failure drugs soon. Okay, so you all know, right? Heart failure is asked in 3 years of your MBBS. Second year, pharma will ask it, pathology will ask it. Okay, both will ask. Okay, then third year, PSM will ask when it will talk about non-communicable diseases. Okay, it comes in the national program for non-communicable diseases. Okay, then your medicine is always there to ask about heart failure if others have asked or not asked. Okay, so you cannot escape from heart failure. That is why we chose this topic for you. Okay, now, so if your ejection fraction from reduced ejection fraction heart failure patient improves after treatment, there is a separate entity by AHA, American Heart Association, which calls it as heart failure with improved ejection fraction. So any heart failure patient who had first ejection fraction below 40 now shows an improvement of 10 points above what was the baseline, and it is more than 40% after treatment. That is second ejection fraction. It is known as heart failure with improved ejection. Okay, sir. Understood. Classification also over. Sir, you were talking about something regarding treatment. Okay. I only was talking. I'm talking to myself actually when I cannot hear you. I am asking questions from your end to myself. Now, treatment of heart failure is actually very simple. I'm trying to make it as concise as possible to fit it in within the time frame of 1 hour. 1 hour is actually not sufficient to discuss heart failure in toto. Okay, I discussed with my students for 4 or 5 days altogether, and we were only talking about heart failure, and still it is half left. Okay, so that much is the extent. So please excuse me if I'm missing some points in this. Okay, you can always go back to your books and come back to me anytime. Okay, now say for example, your left heart I'm talking about. What is the preload to your left ventricle? What is the preload to your left ventricle? This is my question. Let's see how many can respond to it. I need answers. Answers. Preload to the left ventricle. Team, please check it if they're answering. What is the preload to your left ventricle? And it is not venous return, I'm telling you. Be more refined in your answers, more refined. Tell me the answers they are telling. So it is. Yes, this is the right answer. So it is the end diastolic volume to the left ventricle. Your end diastolic volume to the left ventricle is actually the preload. Okay. If it is, if it is high, the cardiac myocytes will be stretched. And tell me what all gets released from the cardiac myocytes once they get stretched? We get the natriuretic peptides. Physiology. Okay. So the natriuretic peptides are released. The natriuretic peptides, when these are released, okay, what will happen? They promote diuresis. They promote diuresis, and they will inhibit your RAS. Okay, renin, angiotensin, aldosterone system. Okay, will be inhibited. So to diagnose heart failure, we can actually use the levels of these natriuretic peptides. We actually do it in clinical practice. So just having an ECG or 2D echo with ejection fractions is not the only diagnostic modality for heart failure nowadays. There are much more etiology which is causing your heart failure. ECG will have ischemic changes. If there is a hypertension, systemic hypertensive patient, ECG will have left ventricular hypertrophy. Okay, so there can be ECG changes in any case of heart failure depending upon the etiology you are having. Okay, I'll not go in much details of ECG here. My students have had enough of me for ECG. Okay, now, so we will go in to the diagnosis of heart failure. So we discussed ECG. 2D echo, ejection fraction we have heard of. Then we will talk about structural cardiac abnormalities in 2D echo. If there is a left ventricle hypertrophy, if there is any valvular heart disease, like if there is MR, if there is AR, if there is PR, whatever the valvular pathology we are having, we can detect it in a 2D echo. That's it. But what else? That brings us to two entities. One is cardiac biomarkers. Another one is your natriuretic peptide levels. Okay. So natriuretic peptide levels are actually used as a marker for heart failure. Okay. So levels of NT-proBNP will be raised far normal in a case of heart failure. I have seen patients who have natriuretic peptide levels of more than 17,000. That shows you the extent of fluid retention such patients are having. Okay. So this tells you the load to the heart, the preload to the heart, how much your cardiac myocytes are getting stretched to accommodate this increase in the fluid. Got it? Okay. Now, so your natriuretic peptide levels are elevated. Sir, you talked about cardiac biomarkers. What are they? Troponins, CPKMB, LDH. Okay, we have read it. These all are cardiac biomarkers which can be elevated. Okay, so depending upon the physiology which is becoming pathological, you will have the diagnostic modality and you will have the treatment. Okay, so now physiology was end-diastolic volume. Pathology was heart failure, myocyte being stretched. Okay, and the diagnostic was natriuretic peptide elevated. Okay, treatment is sir reduce the preload. ठीक है, preload कम कर दो, treatment हो गया आपका. Okay, कैसे करोगे preload कम? How will you reduce the preload? Diuretics. Okay, give diuretics. If kidneys are normal, they will push the excessive fluid out and the preload will be reduced. So in that patient which I was talking about 17,000, we brought down it to 4,000 within 2 days of diuretic therapy. Continuous pump of furosemide we gave in infusion. And we were able to drain out more than 4 liters of urine per day just with furosemide. Okay, just this simple basic understanding will improve the life of your patients. Okay, just imagine the sigh of relief that heart would have had once that extra fluid was pushed out. It's like another life, another birth. Okay, and the understanding is this simple. Physiology and diastolic volume, stretch of the heart muscles, NT-proBNP elevated. You are giving diuretic. You are decongesting the heart. It is not this simple. I'll tell you later. Now, so diuretics you have understood. Just joking. Now, diuretics over. Now, see, we talked about myocardium being distended. We talked about preload being reduced. What about the afterload? I talked about systemic hypertension as an etiology for heart failure. Okay? So, say for example, I used to have one of my favorite students. I am not having him right here. Okay. Okay. Now, and these girls are actually running the slides for me. These are actually running the show for me, so I cannot push them out. So just imagine there is someone whom I have to push out of the door. Okay. And say, for example, there is someone who is standing on the other side of the door to prevent me to push this someone out. Okay. Just imagine. इमेजिनेशन में तो कुछ नहीं जाता, बैठे बैठे ही करनी. Now, say for example, I have to push it. There is someone. So if someone is not there out to stop me from pushing this person out, I will be able to push easily. Okay. Now, say for example, there is someone who is as healthy as me and is stopping me. Now, I will have to exert more force in opening the door. Okay. I am putting some more force and I am able to open it. I am able to open it. Now, if that someone goes to a gym, builds up muscles, okay, comes to push, prevent me from opening the door. Now, I will start to fail. I will be like, no, 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 no. I still have to push somehow. I have to open the door. Now, what I will do? I will go again to the gym. Okay. I will also build up muscles. I will become hypertrophy. Okay. Now, to increase the force of my pushing out, I will put more force to open the door. Now, I am able to open it. But that person is stronger than me. Now that person is also going to gym again, is able to build more muscles than me. Now I will surrender. I am not able to push anymore. I declare my failure and I start to fail. This is what is happening in systemic hypertension. That there is more than normal pressure in your aorta. Okay. See, to push blood from left ventricle. Same concept like in left atrium and left ventricle. Same concept here also. To push blood from left ventricle into the aorta, we need a relatively negative blood pressure in the aortic root. Okay. Then only I will be able to push now. My aortic valve will open and the blood will go from left ventricle to the aorta. Now, in systemic hypertension, where there is increase in the total peripheral resistance, physiology की घंटी बजी सुना, systemic vascular resistance in, okay, which is the organ which contributes majorly to the systemic vascular resistance? I only will give answer. It is kidneys. Okay, so kidneys contribute maximal to the systemic vascular resistance. Okay, now systemic vascular resistance increased, your blood pressure is elevated, and the heart is facing difficulty in pushing the blood which is accumulated inside the left ventricle out into the aorta. First, it becomes hypertrophied so that it is able to exert more force out. But Frank Starling law comes into picture. All of you have heard Frank Starling law? Yeah, the students sitting here have heard. So I imagine that you also have heard because there is less time left now. So the Frank Starling law states in the end that it is only in the physiological limits. Okay. So it's only in the physiological limits that you can increase the force of contraction. Beyond that, no, the graph comes down to downslope. Okay, so that is what happens here. Simple concept. Okay, so because of this, despite being hypertrophied, there is limitation in the force of pushing the blood out. And because of this limitation in systemic hypertension, we fail. So Treatment? Sir, reduce systemic hypertension. And systemic hypertension was afterload to the heart. Total peripheral resistance is the afterload to the heart. Okay. Now, afterload, how do we reduce? Sir, number one, we give vasodilators. Vasodilators will reduce the systemic vascular resistance. Over. Then we give other antihypertensives like ACE inhibitors, ARBs. Okay. And the newer entity, which is ARNIs, ARNIs. Okay. Angiotensin receptor neprilysin inhibitor. Okay. Now, see, these drugs which just now I talked about do much more than reducing the afterload. They prevent the cardiac remodeling, which I was talking about earlier. You can always read about cardiac remodeling into depths of details. It's given in detail in your Robbins of pathology. Okay, so you can talk about. So the eccentric hypertrophy, concentric hypertrophy, it talks about in details. Where the non-hypertrophied remodeling also it talks about. So you can always read about. I will not discuss that into detail. Okay, so these drugs, ACE inhibitors, ARBs, ARNIs, they prevent cardiac remodeling. Cardiac remodeling is a double-edged sword. It will increase the heart function temporarily, but then the heart is bound to fail. Okay, so these prevent. Then ARNIs, what is neprilysin doing? Neprilysin, normal, in normal setting, neprilysin, what does it do? It cleaves your natriuretic peptides. So your natriuretic peptides will be cleaved and deactivated by neprilysin. By inhibiting this neprilysin, we are actually increasing the action of your natriuretic peptides. Okay, so your diuresis will be promoted. Okay, your RAS will be inhibited. And we always combine ARNI. We use most commonly used is sacubitril. Okay, with a combination of ARB, that is valsartan. Okay, so sacubitril and valsartan is actually very beneficial, and all the guidelines promote it. Okay, then what? Sir, initially we were talking about reduction of the function of the heart because cardiac workload was increased, myocardial oxygen demand was increased. How to improve this? And we come to a very important class of drug, which is beta blockers. Beta blockers reduce the heart rate. They control the heart rate, and your myocardial oxygen demand will be low. Okay. And your workload will be reduced. So heart will have ease of doing its job. Used as an anti-diabetic drug, but has found its space in cardiology. Those are SGLT2 inhibitors. Okay. So SGLT2 inhibitors. SGLT2 inhibitors, kidneys, located in the kidneys, these will cause excretion of sodium and glucose along with water into the urine. Okay, thereby reducing the preload. And again, what will happen? The heart failure will improve. Then, apart from this, what we use is, see, In heart failure, there are four stages. Stage A, where the risks are present, but the patient is not having the disease. Stage B, where heart failure is present, but you are not having the symptoms. Stage C is where symptoms appear, which we have talked about till now. Okay. Then D is advanced heart failure, or what we call it as acute decompensated heart failure. So if we do not treat a heart failure, it lands up into advanced heart failure or acute decompensated heart failure. And moreover, if there is again two lines here, if we do not treat, it is advanced failure or ADHF. And if we treat, but the patient does not respond, if we are giving adequate treatment and the patient is not responding, then again it is an acute decompensated heart failure or advanced heart failure. Okay. Then we talk about surgical aspects of heart failure. There are certain surgical modalities also which are coming into picture nowadays. We'll discuss about it sometime later on. I think I'm already overrunning the time. So this was a brief introduction. I think I have crossed that brief landmark now. Okay, so it was a brief introduction of heart failure from my side, from the complications till treatment. I have tried to cover almost in entirety, if not entirety, around 70% of heart failure, which is what is required to an undergraduate student. Okay, post graduation, sky is the limit for heart failure. Okay, but for undergraduation, at least this much you should know, and it is nothing but basic anatomy and basic physiology, which leads you to understanding of a complex entity of heart failure in a simple manner. I think you know your heart a little bit more than you knew 1 hour before. Thank you so much for being with me in today's lecture. Hope to have more opportunities like this so that I can share whatever I have with students like you with interest. Thank you so much.
Thank you so much, sir. I would request the participants to kindly ask their doubts, if any. However, it was a very mind clearing session. Thank you so much, sir, again. If any participant has any doubt regarding the session, they can put up the question in the chat group and sir can answer them.
Any doubts regarding heart failure are most welcome. And there is nothing called a silly question. You can ask anything about heart failure to me. Okay. Okay. It's a very nice question. So, how does diabetes mellitus leads to heart failure? Number one, the heart failure in diabetes is more of diastolic heart failure than systolic. Number one. This is one thing which we should know. Another one, it is the advanced glycated end products. Okay, the advanced glycated end products, they get deposited in the heart. And because of this deposition of advanced glycated end products, plus there is, see, diabetes mellitus nowadays is classified as an inflammatory disease. It's an inflammatory, chronic inflammatory state. Any metabolic syndrome, be it obesity, be it hypertension, be it diabetes mellitus, is an advanced inflammatory state. And these inflammatory cytokines, which are elevated in these conditions like diabetes mellitus, okay, will lead to, again, what we known as diabetic cardiomyopathy. And this diabetic cardiomyopathy, which is damage or remodeling of the myocardium of the heart leads to heart failure in a diabetic patient. Nephrotic syndrome leading to heart failure. See, I couldn't cover these aspects of other organs related to heart failure in detail because of actually scarcity of time. But yes, nephrotic syndrome leads to hypoalbuminemia. If there is hypoalbuminemia, what will happen? The again there is increased fluid accumulation. There is fluid overload. Okay, there is fluid overload, and any fluid overload in if it is present in a greater extent and in a greater volume for a longer duration of time can precipitate heart failure with the same concept we talked just now. And it is also a two-way thing. You talked about a kidney leading to the cardiac problem. Heart also can lead to a renal problem, which we proudly call it as cardiorenal syndrome. Okay, so if there is hypoperfusion of the kidneys, EGFR will be low. If EGFR is low, your kidneys will shut down. Okay, so it is a two-way thing. Then kidneys, if they are getting involved and there is uremia, if there is uremia directly affects heart. Okay, so there is what we call it as uremic pericarditis. Okay, then if kidneys, there is hyperkalemia because of a renal disease. Hyperkalemia will trigger arrhythmias by increasing conduction in the heart. So it is a two-way thing. Heart can lead to a renal disease, cardiac disease can lead to a renal disease can lead to a cardiac disease. Both can happen. Any other questions? So is it clear or all clear?
Yes, sir. I guess the topic is very clear for everybody. Thank you so much for answering to the doubts.
You're most welcome.
As we conclude the enlightening session, I would like to express a sincere gratitude to our esteemed speaker, Dr. Kushal sir, whose insightful lecture on heart failure has significantly broadened our understanding of this critical topic. Your expertise and eloquence have left us all better informed and inspired. Thank you so much again. I would also like to extend a heartfelt thanks to Dr. Ajay Mahajan, President of IMA Haryana, Dr. Dhirendra Soni, Secretary of IMA Haryana, and Dr. Punita Hasija, State Chairperson of IMA MSN Haryana, for their unwavering support and dedication. Your contributions have been invaluable in making this event a success. I would also like to thank the participants for making this event a success. Thank you so much, everybody, for attending this session. With this, we would like to wrap up the session. Thank you so much, Kushal sir. Thank you, everybody.
So much. Thank you so much.
Thank you so much, sir. Thank you so much, everyone, for extending us the opportunity to host the session. So, with all your permission, I'm signing off here and looking forward to host you again.